You can hear me and you can see the screen, right?
Yeah.
Perfect. So I'm Andrew. For those who don't know me, I'm just going to start on on the afternoon report. This is based on a patient that I saw recently at Sloan Kettering, actually. So the one-liner. So this patient, he's a 74-year-old male who presented to the hospital for direct admission for AKI. So just a little bit about his HPI. So he's a 72-year-old male with a history of JAK2 positive essential thrombocythemia, a history of bilateral PEs and left lower extremity DVT, hypertension, hyperlipidemia, emphysema. And he presented to the hospital for a direct admission for AKI. Regarding this AKI, so his baseline was around 1.3. But for the past 2 months, it has increased to 2.5 at his most recent office visit. He's also endorsing bilateral joint pain in the shoulders, hips, and knees that also started around 2 months ago, and it has progressively worsened. These joint pains, they persist all day. They're not particularly worse in the morning, and he's having some difficulty ambulating now due to the discomfort. But he has preserved range of motion and he's taken Tylenol for the pain, which seems to help a little bit. He also endorses some weakness, generalized weakness and dyspnea on exertion, but denies any fever, chills, chest pain, abdominal pain, diarrhea, constipation, urinary discomfort, changes in urine color, or changes in urinary frequency. And just a little bit about the outpatient workup so far before he was admitted to the hospital. So shortly before admission, UA was positive for proteinuria and hematuria. He was actually given IV fluids, but his creatinine didn't improve. So regarding his past medical history, so he has a history of essential thrombocythemia, bilateral PEs, and left lower extremity DVT. Which happened back in April of 2021, emphysema, anemia, hypertension, hyperlipidemia, peripheral artery disease, and diverticulosis. He has a past surgical history of a right fem-pop bypass, and his social history is significant for, so he was a former smoker and he was a former alcohol user, but he quit back in March. And he has no reported family history. Regarding his medications, so right now he was on anagrelide, which was used to treat his JAK2 positive essential thrombocythemia, Eliquis for his history of PEs and DVT, omeprazole, aspirin, Hydrolyzing, amlodipine, atorvastatin, metoprolol, and an inhaler for his emphysema. So on review systems, the pertinent positives for this patient, so he was complaining of just generalized fatigue, but he wasn't endorsing any fever, chills, night sweats, or weight loss, or decreased appetite. Neurologically, he didn't endorse any headaches, focal weakness, or dizziness. And he didn't have any visual changes or hearing losses or sore throat, no chest pain, palpitations. He is complaining of dyspnea on exertion, but no cough. And when I talked to him, it sounded like this dyspnea on exertion was actually a chronic issue. He has no abdominal pain, diarrhea, constipation, no nausea or vomiting, no melena or blood in the stool. And he has no changes in urinary frequency. He has no hematuria or dysuria and does not endorse any flank pain. He does have the bilateral shoulder, hip, and knee pain, but he has preserved range of motion. No new rashes, no new itches or bruising. His vitals, so his vitals were stable on admission. He was afebrile, BP is 120s over 60s, heart rate in the 70s, respiratory rate 18, and he was saturating well in room air. He was in no distressed when I saw him. So on exam, he was learning oriented. Physical exam was really only significant for decreased strength in the joint muscle, in the joints that I mentioned previously, so in the shoulder, hip, and knee. But other than that, everything else was negative.
I guess before we go there, anyone has any questions that you want to ask about the patient, about the history, or anything that maybe you would have asked this patient if you saw him in the ED? I guess I have a question actually. I wanted to know, so we were saying that he had this worsening of creatinine over 2 months, and I was wondering.
Sorry, Julia. Your mic is cutting in and out a lot. Maybe I think if you want to switch with the other camera or microphone. But I guess if anyone else has any questions that you want to know on the history of physical, if you want to post them on the chat or unmute yourself. So Tyler's asking Andrew if there's any changes in his medications recently. I know there was quite a long list there, if anything had changed.
So he was on hydroxyurea for his essential thrombocythemia before, but then he was subsequently taken off because he was having progressive anemia over the past 2 months as well. And his hydrolyzing was actually, the dose of it was increased back in April. But other than that, most of his other medications were longstanding.
Can you hear me now?
Yeah, much better. I'm not sure what that was.
Sorry, I don't know what happened. We changed the mic. I was asking, so this increasing creatinine, was it because they checked the labs multiple times on those 2 months, or they checked it like 2 months ago and now they checked it again?
So they checked in multiple times. I want to say it was maybe four or so office visits. So it was tracked over time over those 2 months.
And it was increasing over the 2 months, or it was like, it was increasing? Okay.
It went from like 1.3 to 1.6, then it was 1.9 or 2, then it went up to like 2.3 and then 2.5, something like that.
Okay. Anyone has any other questions? Weight changes?
So he did not endorse any recent weight loss.
Anything else you're curious? Okay. Was the proteinuria, hematuria on this dipstick or UA with microscopy?
It was on UA with microscopy. And muscle pain wise, so he doesn't endorse muscle pain specifically, but he just talks about generalized fatigue and weakness.
I'm just curious, Saul, why did you ask us that question?
I don't know.
Basically, to confirm, it was hematuria in a patient that has muscle weakness and not like myoglobin noted on dipstick. And I was just about to ask if anybody noted a cast on that microscopy.
There were no casts on the microscopy. Great question.
Yeah, so he's making a good point. And when we do a dipstick, if it's positive, that might just be the hemoglobin. So we don't know if it's actually red blood cells or if it's, for example, myoglobin. So that's a good point. Martin and Debbie are asking, any changes in appetite or fluid intake?
He hasn't had any changes in appetite or fluid intake.
And then are the worse in the morning or evening?
In terms of the joint pain, I think it was pretty much consistent throughout the day. When I asked him specifically if it's worse in the morning, he didn't say no. He didn't say yes. So it sounded like it was just persistent throughout the day.
And about how long is he taking anagrelide?
The anagrelide was started in September, and he was admitted at the end of September.
Okay. And Sam, is the dyspnea new?
Not new, but it was a chronic issue. But he also has a history of emphysema.
Okay. Again, I guess like a question I had, when you did a physical exam of the joints, was there any sign of inflammation, or they were totally normal?
Totally normal. No effusions, no swelling, erythema, nothing like that. It was really just the decreased strength at those joint points.
Okay. Okay, so anyone that wants to put together the information we gathered so far, do our summary statement, so we kind of like go over, you know, the age of the patient, the age range of the patient, and like the information that we think are important for our differential diagnosis.
I can try.
Go for it.
Okay, so our patient is an elderly male with a past medical history of JAK2 positive essential thrombocytopenia, PEs, DVT, emphysema, anemia, hypertension, HLD, and diverticulosis. Came in with persistently increasing creatinine of 2.5 from baseline of 1.3, with accompanying 2-month history of bilateral joint pains on the shoulders, polyarthralgia, and then also with a chronic dyspnea and exertion, with unremarkable vital signs and normal PE, just pertinent for the weakness of 4 out of 5 on 4 extremities. So this patient was admitted for workup for AKI, workup and management for AKI.
Perfect. Yeah, I think you put a lot of information. It's important also in this case to know the vitals, because we want to know if, for example, the patient is having any hypertension or hypotension, which are very important in terms of AKI. We want to know if there's any changes in medication. So I like that you put all of this information. The dyspnea, I don't know if it's very important just because now we know that it's not a new thing, but if it was a new thing, definitely we want to put it there. And then I think something we didn't ask, it's also if the patient was making urine. We don't know if it's polygoric or anuric, so that's something that we also have to kind of put together when we are assessing an AKI. So perfect. So I guess like before we go and find out more about this patient, I just want to talk to you about what would you do and how would you approach this type of case. So when we have someone that comes in for an AKI, what's our usual? I think everyone uses the same framework, and what is it? Anyone?
Pre-Renal,
Renal, post-renal, perfect. So we all use the same, right? So let's try and kind of go over it, so that I think it's always good to have an idea so that we can kind of put the patient in a couple of these blocks and then like work out the patient like that, okay? Especially because it's kind of like a very complicated case. We have some information that are not that clear. So maybe we can start with the reason why the patient is coming and then work up there and see what else we need to know. So I'm kind of trying to create like a nephron or something similar to that. And let me just, so this is our glomerulus, and these are our vessels that are around the kidneys. Okay, so now, so this is everything before the kidney. So this is our pre-renal area. So what are causes of pre-renal AKI? Low volume. So everything that decreases the blood flow to the kidneys, right? And what can do that? So yeah, hypovolemia, poor oral intake. So hypovolemia from basically anything, diarrhea, poor oral intake. So Sam, you're saying embolus infarction, definitely. So that will decrease the blood flow, but most of the time that will be unilateral, right? So you might have the other kidney that's working, and then embolus, it can cause AKI, but it's usually more like a vascular type of injury that will create some parenchymal injury. So it's in between, depends probably on the situation. Yeah, sepsis, vasodilation, absolutely. Shock, yeah. So any situation of hypovolemia and also shock. Renal artery stenosis, yes, but it kind of has to be bilateral, and usually it's more like a chronic thing. So it might cause like a worsening kidney function. I don't know how acute that will be, but definitely also renal artery stenosis. And then something we didn't mention, but that's so common in our patients. Like all our patients have it. CHF, so cardiorenal syndrome. So also like overload of fluid will also cause a decrease. Yeah, also cirrhosis and perfect, exactly. So all of this. I think most of our AKIs are going to be pre-renal. So a lot of the times we kind of do a fluid kind of challenge to see if that's going to help our patient. And then we all know, I guess, these kind of rules that the BUN creatinine ratio is going to be more than the 20/1. So drug use like cocaine, yes, that can cause it. It can also cause vasculitis. So yes, absolutely. Also cocaine is something we always ask if we have no idea why the patient is coming with an AKI. We sometimes use FeNA. I know that I think it's controversial because actually the FeNA and the Fiuria sometimes are not that specific. So so many times you order the electrolytes of the urine, but we cannot kind of use them 100% to guide our diagnosis. I think that's something that we need to keep in mind. What's the usual FeNA for a pre-renal AKI? Anyone? You can even type it in the chat. Less than 1, perfect. And when do we use the Fiuria? On diuretics. Oh, perfect. And that's usually less than 35%. I think another important thing that when we have a pre-renal, there's no damage on the kidney, okay? So the urine sediment will be bland. We don't have cast, we don't have anything usually. We can have hyaline cast because the urine might be sometimes concentrated, but we don't have anything. The urine are bland. So now let's go to our post-renal. So post-renal is anything that blocks the urine from coming out of the kidneys, okay? So what do we have? BPH, what else? Stone, cancer, absolutely. So most of these things have to be either very distal, so like in the bladder, because we have to block both of the kidneys, or they have to be unilateral if the other kidney is already damaged. So for example, if we have just one stone on one kidney, unlikely that we will have such a bad picture that we will have a severe AKI. But if we have like bilateral stones, so the stone is very, very distal, definitely. Yeah, perfect. Neurogenic bladder, that's also possible cause. So cervical, yeah, any type of GU cancer, GYN cancer can do it. Perfect. In this case, like the urine is not going to be that helpful, right? So in the post-renal AKI, also the urine are pretty bland. So how do we diagnose this? What do we do if we're suspecting a post-renal? Ultrasound. What type of ultrasound do you think will be our first line? Okay, so that's where I wanted you to answer. That was a tricky question. But yeah, we do renal bladder ultrasound like kind of all the time, but technically it's one of those things we do for no reason. And technically a bladder scan will be much faster, economic, and usually enough to see if there's an obstruction. Of course, if we have no idea or if the AKI is not getting better, definitely get an ultrasound of the kidneys, but technically a bladder scan or a trial of a cath will be enough. And I think the point right now is that I wanted to say that almost 80% of our AKI will be either pre-renal or post-renal. So mostly if we give some fluids or if we do a bladder scan, we will have a diagnosis, okay? Now let's go to the most complicated part, so the intra-renal. So intra-renal, what are some clues of intra-renal AKI when we do a UA or when we look at the blood? So definitely proteinuria. So the sediment will be positive and we might have protein and blood. And this is because any intra-renal cause will create some inflammation. So I think that's what we have to remember. So if there's inflammation inside the kidneys, things that are not supposed to be in the urine will be in the urine. So if we find blood, casts, dysmorphic RBCs, white blood cells. So most likely this is going to be in the kidney. Something is wrong in there. Perfect. And then we have our usual rules. So BUN creatinine is going to be less than 10.1. And then our Phe and Phuria, even though we already said we don't really go by them most of the times. So that's going to be more than 1%, and the Phuria is going to be more than 35. So I think a good way to divide them, at least in our minds, is anatomically. So we can start here. So this is our glomerulus, and I apologize for how I draw it, but okay. So what are the causes of glomerular AKI? Come on, go crazy. It's very, very, very easy. Glomerulonephritis. Okay, perfect. So glomerulonephritis, how do we divide them? They're a little tricky, and unfortunately, you will have them on the boards. But so glomerulonephritis, absolutely. So the first thing, usually they cause, so AKI, that's why we're talking about them. Then will cause hypertension, and then we will have positive UA. So we will have protein, we will have red blood cells, and sometimes we have dysmorphic red blood cells. Someone was saying red blood cells cast, but they can be absent. So that's not a way to rule them out. And yeah, then nephritic versus nephrotic, absolutely. So that will depend on the etiology of the damage of the glomerulus and amount of protein that we will spill in the urine. And then usually in terms of diagnosis, we will divide them in POSI immune, immune complex mediated, and then we will divide them with anti-GBM. So this is a little bit more specific, but it kind of depends on when you do a biopsy and you kind of like look at the immunofluorescence. And then if it's POSI immune, it just means that there are not a lot of complexes. And this is usually because of the ANCA antibodies. We can have P-ANCA, C-ANCA, and some of them are actually negative, like the Churg-Strauss, EGPA, most of the times will be negative for antibodies. Immune complex, there's like so many. We have some of them with C3 and C4 that will be decreased. For example, lupus nephritis, MPGNs, or drug-mediated. And some of them are depending on the IgA, so like IgA nephropathy or the Hinox-Schönlein purpura. And then anti-GBM is just one, so it's the anti-GBM. One thing to remember that with glomerulonephritis, the proteins are usually albumin. So the bulk of the protein in the urine will be albumin. Okay, so now let's go to our tubules. What are the causes of AKI that comes from the tubules? How do we call it? Probably one of the most common type of ATN, absolutely. So ATN, we have our muddy brown casts sometimes. And what are the causes of ATN usually? Drugs, yes, a lot of like amphotericin, for example, ischemia, yeah, toxin, exactly. Also remember, any cause of pre-renal, if it's not treated, can cause ischemia at one point. So everything can kind of like become ATN at one point if we don't take it in time. And that's also why we sometimes do a fluid challenge to see if the patient is responding to fluids or if now the damage is actually done. And then also, yeah, so stroke, so anything that can, you mean stroke. So contrast, yes, it's really, really controversial, but yes, contrast will give you an ATN type of picture. And then ischemic, yes, Richard, ischemic in terms of if there's anything that's blocking the flow, that's gonna like develop an ATN. So yes, Lenisa, there is interstitial nephritis, and we'll put it here in our interstitium. The other thing for ATN is pigment. So myoglobinuria, it's actually a cause of ATN, okay? And then in the tubules, we can also have obstruction of the tubules, which is not exactly ATN. We don't have muddy brown casts. But for example, if we have crystals, and then like a question I had my boards, for example, was about backstream. So backstream can actually crystallize and can give you an increase of the creatinine because it creates this kind of like obstruction of the tubules. Or IV cycloprid, that's also a classical medication that crystallizes in the tubules. And I almost forgot paraprotein. So multiple myeloma will also give you obstruction. So that's how it causes AKI. So going to the interstitium. So as Lenisa was saying, so we have AIN. What's the classical findings that we're gonna study in our books about AIN? When we look at the urine, what do we learn usually? What do we find? Eosinophils and white cell cast. Exactly. So these are classical findings, but they're not pathognomonic. So even if we have them, that doesn't mean that we have AIN, but definitely we will think, oh, maybe this is an AIN. What's the most frequent cause of interstitial nephritis? NSAIDs, absolutely. So medications. So NSAIDs, and then what else? Okay, penicillins, yes. And then there's like another one, which is PPIs. Yeah, PPIs, because sometimes we don't think about it, but PPIs also can cause AIN. And then other causes can be infections or even autoimmune diseases. Bacterium. So bacterium usually is more a cause of obstruction, but bacterium has many ways of causing AKI, so it can also cause AIN. It's kind of like that drug that is a bit everywhere. And then lastly, vessels. So the last type of intra-renal AKI is from our vessels. So anything that, for example, vasculitis will cause damage of the kidneys. And then here we can put also, H2S, CTP, anything that causes kind of TMA will cause damage, will cause leakage, we will have an AKI. So now we have our patients, okay? So we know, I think we have a lot of information that we can use in this case, okay? So we know that he has an AKI, which is actually kind of worsening for 2 months. So this is really bad. We also know that he got fluids and is not improving. So that helps us. And we know that he has a positive UA for protein and blood. So if you were to approach this patient today, where would you put his AKI? Okay, renal, absolutely. Okay, I think we're on there. And we can even have a pre-renal that now became renal. Anyone thinking of post-renal as a possible cause? No? I mean, I don't think either, right? Because he would have been totally anuric. It's been 2 months. We would have found out if he had an obstruction by this point. Okay, so now how do we find out? What are the steps that we go for in the ED to find out what you just told me, that it's a renal AKI? What blood work, what lab work do we do? I'm gonna call you out if you don't tell me. Okay, so perfect. So first of all, I just want to say we start with the history, but we already got that, so perfect. Then we get UA, so we repeat the UA that you already had. And I think Saul made a good point. So we don't only do the dipstick, but we want to look at the microscopy. So we want to look at what's in the urine. We want to look at the cast. We want to look at if there's a red blood cells, if the white blood cells. We do a UA with microscopy. And then urine lights. Yeah, we most likely will order urine lights. We already said that they're not always helpful for an AKI, but we would have more information, so why not? And then creatinine, yes. So we do a BMP, right? So we want to have an idea of the creatinine, of the BUN, but we also want to look at lights. We need to see if we need to, I don't know, treat an hyperkalemia, treat something that's wrong in the BMP. So let's say like this patient. So we know that he has protein. Do we stop there? What do we do and why? Electrophoresis. So why electrophoresis?
In my differential, I'm also like considering like multiple myeloma, sorry, if he also has like pains and he has like anemia.
Yeah, so definitely. So the first step though, that's absolutely right, but we need to know how much protein the patient has. So with a UA, we don't know how much it is. And even if we have a a number, we cannot really quantify how much protein is it excreting. So whenever we find protein, we need to know how much. So the next step would be to do a protein creatinine ratio, which we can do in a spot urine because it's very similar to the 24 hours. And then depending on that, absolutely, we will go and look for multiple myeloma or anything else. And usually if it's more than one, it's kind of pathological, right? We usually have a normal 0.25, 0.5 or protein creatinine. So if it's more than one, we already know that this is not normal. And so let's assume that he does have this. So we already said that we want to do an SPEP and UPEP to look for multiple myeloma. What else do we do? What do we have to rule out? We already talked about it, right? All the causes of intra-renal AKI. So what type of blood work would you guys do? Yeah, so, okay, ANCA, absolutely. CBC, yes. Exactly, so it's everything we just talked about. So we kind of want to rule out the different types of possible glomerulonephritis or nephrotic syndrome. Maybe we could even, like, this patient does not have diabetes, but let's remember that the first cause of nephrosis is also diabetes. So if the case was different, we might want to also check an A1C, but usually abnormal diabetes wouldn't cause proteinuria in a couple of months. It takes years, but just to put it there. And then we have to know there's a lot of infection like HIV, HPV, HCV that we have to look for when we kind of like rule out glomerulonephritis and nephrotic syndrome. So that's when we call nephrology and we start doing all this blood work. This is because the protein creatinine ratio is abnormal and we have to kind of figure out what's going on. When would you guys do a biopsy of the kidneys? Never, or is there any specific indication that you might think of? Okay, I mean, it's a little tricky. I think in general, in this case, you always call nephrology, but when all the times, if you have an AKI undiagnosed and you have positive protein, you need a biopsy. And actually, a lot of the times, even when you have some of this blood work that we were talking about that come back positive, most of the attendings from nephrology will still want a biopsy because they want to make sure what type of pathology they have before they start the treatment. So a lot of the glomerulonephritis or nephrosis syndrome, you will have to have a biopsy, unless you think that the patient has very small kidneys, it's a very chronic condition, and that's not really going to change anything. So in these cases, you will need a biopsy of the kidneys most of the times. Okay, so Andrew, do you want to continue to tell us more about the patient?
Sure. So I'm just going to share my summary statement, which is kind of short, but it's pretty much what you said, Debbie. Elderly male, history of essential thrombocythemia, bilateral PEs, left lower extremity DVT, who presents with worsening AKI and diffuse joint pains, concerning for intrinsic renal disease.
Can you share your screen so we see your slides?
Oh, yes.
Thank you.
You see it now?
Yeah.
All right. So these are the basic labs on admission. So just starting off with the CBC, it was notable for hemoglobin of 9.0. On his BMP, his creatinine was 2.8 on admission, BUN 33, and he was noted to have low bicarb. Hepatic function panel was normal, and this is his UA. So you can see that there's a lot of proteinuria, there's a lot of blood, and there's red blood cells, but no casts seen. And just more labs and imaging. So we talked about some of the workup for AKI, but his FeNA was 2.9%. We got a random urine protein creatinine ratio, which ended up being 1556 milligrams per gram, which over 24 hours equates to around 1.6 grams per day. which means it's elevated and not yet in the nephrotic range, which is usually above 3.5 grams per day. And renal bladder ultrasound was negative for hydronephrosis or any signs of obstruction. And so we got some inflammatory markers on admission because we didn't really know what was going on. So just starting off with the left, I just put here all the positive markers that we found. So his ESR, his CRP were elevated. He ended up having a positive ANA, a positive double-stranded DNA, positive antihistone antibody, and he was also positive for PANCA/MPO antibodies. He was negative for anti-GBM antibodies, anti-Smith antibodies, anti-streptolystin O, SSA, SSB, C-ANCA, C3, C4 levels were normal. He was HIV, Hep B, and Hep C negative. SPEP and UPEP were negative. Cryoglobulins were negative. Coombs, haptoglobin, and LDH were all normal.
I guess I had a question. I wondered, did you guys call nephrology, and what was the discussion when you guys had these labs?
Yeah, so we immediately called nephrology on admission. So this patient was actually supposed to see a nephrologist in November, but because it was getting worse, we decided to call nephrology right on admission because we kind of figured that this workup would just be expedited in the hospital. And they're the ones who actually recommended a lot of these markers at first. So just going over the differential diagnoses, I know Julia talked a little bit about this, so the concern at this point was that he was having some sort of glomerulonephritis. And like Julia said, glomerulonephritis can be broken down into three big groups based on staining pattern on immunofluorescence. So throw back to histology, but the first category is pauci-immune, which means little to no deposits on immunofluorescence. So things that fall under this bucket are ANCA-associated vasculitides, thrombotic microangiopathies, and then renal atheroembolism. And under linear deposits, we would think of things like anti-GBM disease or good pastures. And for granular deposits, we would think of SLE, IgA vasculitis, which is typically seen with concurrent GI or respiratory infections, post-strep glomerulonephritis, which would be not typical in adults, but more typically seen in children post-strep infection. Active infection-associated glomerulonephritis, so HBV, HCV, HIV, even things like bacterial endocarditis can cause glomerulonephritis. Cryoglobulinemia, which can be caused from HCV infection, and complement-mediated glomerulonephritis. So here's just the diagram that I put into the slides. Thank you, Julia, for sending this to me. But it's just another way of diagramming essentially what the algorithm, I guess, for how to approach glomerulonephritis. So it just divides it into the three major categories: pauci-immune, immune complex, and anti-GBM. And I'm not going to go through it all, but it essentially, goes through a little bit of, like, under immune complex, you have things that have decreased complement or normal complement. And then under decreased complement mediated, you have infection-related glomerulonephritis, autoimmune, or cancer. And so on renal biopsy, we eventually ended up getting a renal biopsy for this patient, which ended up showing pauci-immune crescentic glomerulonephritis. So a rapidly progressing glomerulonephritis. But given that, with the final biopsy results and the serologies, which were positive for ANA, double-stranded DNA, and ANCA-MPO antibodies, and his history of hydrolyzing use. The final diagnosis was determined to be drug-induced ANCA-associated vasculitis, secondary to hydrolyzing use. Pretty rare diagnosis. So just a little bit about it. I'm not going to talk about it too in depth because it's pretty, you're not going to see it too commonly. So some of the key points about just the workup of this case. I know it was brought up before about the casts in the UA, but this patient had no casts in the UA, and they still end up having glomerulonephritis. So my first key point is the presence of dysmorphic RBCs and RBC casts are more specific to glomerulonephritis, but just because they're not there doesn't exclude glomerulonephritis, especially in the presence of proteinuria or worsening renal function. And my second point is, if not otherwise contraindicated, renal biopsy can be incredibly helpful for establishing a diagnosis, and definitely consult nephrology in these cases. And lastly, drug-induced ANCA-associated vasculitis is pretty rare, but most commonly caused by hydrolyzing, and can occur years after initiation of the drug. So common drug offenders also include PTU, methimazole, and minocycline. So just a little bit about hydrolyzing-induced ANCA-associated vasculitis. So it's frequently, so this is a distinct entity from drug-induced lupus, but this frequently has renal involvement, less likely to have extrarenal involvement. Many cases are associated with constitutional symptoms such as arthralgias, arthritis, and cutaneous vasculitis. It's very rare in incidence, and can present at any time while taking hydrolyzine, frequently months after initiation. And renal involvement can typically progress rapidly in days to weeks. The pathogenesis of this disease is unclear, but the labs frequently show positive anti-double-stranded DNA, p-ANCA, MPO antibodies, and variable positivity of antihistone antibody, which our patient had here. And on kidney biopsy, we'll predominantly see polyimmune necrotizing and crescentic glomerulonephritis. And the treatment for this, which actually, interestingly enough, on admission, we withheld his hydrolyzine, and he was already feeling better regarding his joint pains, and his AKI improved a little bit on admission, but the treatment would be withdrawal of the offending agent, and also frequently needing immunosuppressive therapy. And that's it.
And I guess I also have a question. Did you guys end up, I don't know, calling rheumatology as well after those labs? And what was the discussion? And like, did he end up getting any treatment?
Yeah, so rheumatology and renal were both involved in this case. And at the end, after the biopsy results and all the lab markers, he did receive 3 days of high-dose solumedrol. And then he was eventually transitioned to Rituxan, I believe, as an outpatient. So he was receiving.
How does he do? Because I actually didn't know a lot about hydrolyzing vasculitis, and I was reading that a lot of patients actually don't get better even with immunosuppressive therapy.
Mm-hmm.
Do you know how is he doing right now?
Yeah, so I looked a little bit back into his chart. I don't know exactly how he's doing now, but it seems like his creatinine is around the 2.0 region, so he definitely has an element of CKD now. And just talking with the nephrologist, it sounded like his, the progression to CKD was likely anyway, or ESRD was likely in this patient. But I'm not really sure because it's only been a couple weeks since I last saw him.
Cool, very, very cool. Anyone have any questions, comments?
What's the typical dosage that causes the vasculitis, like where you start worrying that it's a higher risk?
So yeah, for hydrolyzing specifically, even doses as low as 100 milligrams per day apparently can cause this vasculitis. So it's not, even low doses can cause it, if that answers your question.